Hi, Year 10. This is a video just talking through the PowerPoint that's available on class charts. So this week we're focusing on cognitive behavioral therapy for addiction. So now hopefully you've completed the work and you're feeling reasonably confident on explaining the biological explanations of addiction, in particular looking at the DDR2 gene and neurotransmitters such as dopamine. We've also looked more recently at the behavioral explanations of addiction, so how we learn to become addicted to a substance or an activity through conditioning or through observing others. Now, we're going to focus our attentions on cognitive behavioral therapy, so psychological treatments for addiction. We do need to know a piece of research for this topic, which we'll go through in the next lesson, and then we'll finish off by just talking about how drugs could be used to treat addiction. And then we've done another topic, we've completed another topic, and then we can move on to the remaining topic for paper 1. So the purpose of this lesson and these activities are so that you feel confident outlining how cognitive behavioral therapy is used to treat addiction. And then we've got to get to the evaluation and you being able to identify the strengths and weaknesses of using cognitive behavioral therapy to treat addiction. The outline and the evaluation are very similar to when we've explained cognitive behavioral therapy for depression. In fact, the evaluation is almost identical, which makes it a little bit easier for you to revise and for you to prepare for the exam. When we're outlining, however, we do have 2 very specific key terms that you're expected to know according to the specification, and that is functional analysis and skills training. So this is just a little recap. So if you haven't done this already, you can just quickly pause this video and answer these questions. All I want you to do is I want you to see if you can fill in the blanks. It's going back now a couple of weeks, thinking about these key terms because it's all about cognitive behavioral therapy. So if you want to pause the video, we'll go through the answers. I give you the first letter for each missing word. Have a go without using your notes, and you're just going to self-assess it. Okay, so we'll go through the answers. So the first one, an I, is an assumption about mental processes drawn from observable behavior. Well, that key word is inference. So an inference, we might feel more familiar with that term from history, that we might draw an inference from a source of data. In psychology, cognitive psychologists do exactly the same. So they will observe behavior, they will listen to what an individual or a patient is explaining, what they're talking about, and will make an assumption, an inference about what mental processes are taking place inside their head or inside their brains. The second question, the way we process information from our environment is known as M processing. The key word is mediational. This is more of an A-level key term, so you might not necessarily find it in the GCSE textbooks. It was in the lesson that we went through on cognitive behavioral therapy in the past and the cognitive approach. So mediational processes, it's a more advanced terminology to explain the mental processes that we referred to in that first question. Mediational processes, all the factors that will influence how we process information from the environment, so our input, which results in our behavior, what we often refer to as output. Number 3, a psychologist called E believed that behavior can be explained and treated using the ABC model. Well, this is Ellis. Now, the proper term for the ABC model is rational emotive behavioral therapy, where we also include steps D and E. But the ABC model is extremely important, and we'll see some of the characteristics of the ABC model being used to also explain and treat addiction. So if we just remember, apart from Ellis's name, A is the activating event, B is the behavior that is caused by the activating event, and C is the consequences of that behavior. So the ABC model fits really nicely with that cognitive processing model of A being the input, B being the process, and C being the output. The same applies when we're trying to explain and potentially treat addictive behavior, which we'll refer to later on in this video. Number 4, during cognitive behavioral therapy, a psychologist will actively see the thought processes of the patient. That keyword C is challenge. Now, this is often used as a potential weakness in cognitive behavioral therapy because a psychologist is actively challenging the thought processes. Ultimately, a therapist is trying to demonstrate to the patient and the individual who's suffering from depression, or in this context, addiction, actively trying to challenge their thought process and demonstrate how irrational their behavior or their mediational processes are. And obviously, for a lot of individuals, a lot of patients, that can be quite negative in experience, and they don't like to be told that they're thinking about something irrationally, which often results in therapies failing. And the fifth one, research by March, and that's the name of the psychologist, found that CBT, cognitive behavioral therapy, is just as successful at treating depression as, and the key word is drugs. It's just as successful at treating drugs. So March found this around 81% success rate for cognitive behavioral therapy alone, 81% success rate for drugs alone. And actually, if we combine cognitive behavioral therapy alongside drug treatments, the success of the treatment actually increases to around 86% of patients reporting that they feel better. Now, it's really significant that we accept that cognitive behavioral therapy is just as successful at treating a mental illness like depression as drugs. That doesn't mean it's better, it just means it's just as good. And that's quite significant because we know that one of the major strengths of cognitive behavioral therapy is that it never results in addiction. You can't become addicted to cognitive behavioral therapy. And it also potentially cures the behavior that we are trying to treat, whereas drugs may only mask the symptoms. Now, if you've missed any of those keywords out, they are in the notes section of the PowerPoint, so you can just download the PowerPoint and have a look in that notes section. But we're going to move on. We'll start to focus on these key terms. So if we think about treating addiction using cognitive behavioral therapy, the first step of cognitive behavioral therapy in this context is what is often referred to as functional analysis. A nice, simple way to think of the process of functional analysis is the patient and the therapist will work together to try and identify the triggers. What behavior, what situations, what factors will cause the individual to actively seek out whatever they are addicted to. Now, generally, we think of addiction as drug addiction or alcohol addiction, where it might be withdrawal symptoms that make a person feel compelled to seek out their addiction. But we're trying to think of addiction as more than just being addicted to a substance. It could be addicted to a behavior. So when we start to consider research, we'll have a look at individuals who are addicted to the internet, for instance. You don't necessarily suffer from physical withdrawal symptoms from the internet, but there must be some triggers that make a patient actively seek out the behavior that they're addicted to. So in the functional analysis, a therapist will sit down with a patient, they will talk and try to work out what situations and what factors might make the patient, the individual, start to actually seek out their addiction and start to carry out their addictive behavior or take the addictive substance. Now, this could include emotions, situations, people, places. The list is ultimately endless. There could be any specific trigger for that individual patient. And that's what makes cognitive behavioral therapy a little more time consuming than other potential therapies, because this could take a significant amount of time for the patient and the therapist to do this together. But once they've done this, then they could move to the next stage, and effectively they're just going to write a list of all the potential triggers. So we'll just use functional analysis together to explain alcohol addiction. So we're just going to imagine that an individual has come to a psychologist, a psychiatrist for help with alcohol addiction. So the therapist and the patient will work together to try and work and identify the triggers that make the individual feel compelled to seek alcohol or to drink. And we'll just talk about some of the triggers that the therapist is likely to identify along with the patient. So with alcohol, it's often people. So it might be that certain people make a person want to drink. Now, it might not necessarily be that somebody winds somebody up to the point where they feel, oh, you're driving me to drink. It might be because consuming alcohol is quite a social activity, that some people also consume alcohol, and therefore it encourages an individual, having a drinking buddy, for instance. So it might be that a therapist identifies you really excessively drink with these people, but these other people who are also your friends, you don't really consume alcohol with them. So there we have a trigger of certain people who might contribute to an alcoholic seeking out their addictive behavior. It could be places, obviously bars are likely places, off licenses, but it could also be other places where a person feels and they start to associate the place with consuming alcohol. So that could be a trigger that makes a person think, well, I'm in the place where I normally drink, so I should be drinking. Or it could be social events like birthday parties, celebrations, weddings. These are all social events that are usually involve alcohol in Britain. So it could be that they are triggers that also contribute to a person seeking out their behaviour. It could be exposure, obviously advertisements on TV. It could be advertisements on billboards, on radios, etc. Walking down certain aisles of the supermarket, for instance, could be a trigger that makes a person feel a little more compelled to buy or consume alcohol. It could be just physically seeing other people drink. So it could be in a situation where a person is not drinking themselves, but because other people are consuming alcohol, that also acts as a trigger, making them feel compelled to drink alcohol. Emotions, positive and negative. So even though when we think about alcoholism and alcohol addiction, we generally associate it with negative emotions, people feeling lonely, isolated and unhappy, but it could also be positive emotions that make a person want to drink, such as a celebratory drink. Again, that's often a trigger that's associated with alcohol consumption. It could be stress, factors that increase stress, so it might be specific to the patient, like work-related stress, relationship stress, financial stress. Life events, so significant life events that might make a person feel that they want to drink, whether they're positive life events, like we've mentioned, such as social events like a wedding, for instance, or it could be negative life events like a relationship breakdown or the loss of a loved one. Sleep difficulties, many people who consume alcohol generally do because they find it helps them sleep. I mean, alcohol does not help a person sleep. We have to study sleep at GCSE psychology. If anything, it disrupts sleep more than it actually benefits people. But because people feel that they often fall asleep quite easily after consuming alcohol, if they're struggling to sleep, that might be a trigger making them think, well, okay, if I have a drink, that might help me go to sleep. So it might be positive to have a drink in that context. So a therapist and a patient might work together to get a list of very specific triggers for the individual. So our list here of these bullet points aren't specific at all. They're very broad. So they would be very specific, such as the name of a person, a specific stress factor, or a specific life event that's occurred that might make a patient want to drink. And once they've done that, they'll move to the second stage of treating addiction using cognitive behavioral therapy. And it's often referred to as skills training. And it's just an aspect to think about it is tackling the triggers. How does the patient deal with being exposed to their triggers? So the therapist will work with the patient to understand and learn these skills to effectively tackle or potentially, most likely, avoid the triggers. So it could be, how do you deal with cravings? So if the patient is dealing with cravings, is there other behavior that they could be using or could be carrying out in response to those cravings? There's also assertiveness training to make a person feel more confident to be able to express their opinions and say potentially no to other people and say, no, I'm not drinking, you have a drink, but I don't want to drink. And it could also be motivation, making sure that the patient feels motivated to continue and to not relapse, to they feel motivated for an end goal, whatever that end goal might be. It could be that a patient and a therapist set a reward if a patient can not drink their alcohol, or if they don't carry out their addictive behavior for a long period of time, they might reward themselves with a trip or whatever it might be. So we can motivate patients in that way. We'll just apply it to our context of alcohol addiction. So for instance, one of the most common techniques for somebody who is suffering from an alcohol addiction is that their skills training will encourage them to avoid certain people. So their drinking buddy, for instance, even if their drinking buddy is not an alcoholic, it might be, don't go and meet that person. You need a period of your life to avoid that person until you feel confident enough or you feel that your addictions come under control. It could be places, so avoid certain places, like obviously a bar, but it could also be an off license. It might be if you go to a supermarket, don't go down the alcohol aisle, or completely avoid visiting the supermarket, use the delivery service to potentially avoid walking past any alcohol that might be on offers. It might be social events. It sounds a bit strange, but you might encourage a person to avoid social events such as parties, celebrations, or maybe just change how they go about this. So purposefully drive, for instance, so that they don't drink because they have to drive themselves home or be the designated driver. It might be if they go to a social event that they go in the afternoon rather than waiting or going to social events later in the night where, again, there might be more pressure to consume alcohol. It might be reduce exposure, like we've kind of talked about. It could be develop new strategies to deal with positive and negative emotions. So if a person does experience a positive and negative emotion, is there other ways that they could celebrate? So instead of turning to alcohol in this context, could they turn to other behaviors? Could they reward themselves in other ways? And the same with negative emotions. If they're feeling unhappy about something, maybe they could talk to other individuals, or they could carry out other activities that they feel that are rewarding or distract away from the negative emotions without feeling the need to go back and consume alcohol. It could be that the patient is taught new strategies to tackle stress. So stress management, it could be meditation, breathing, exercises, or they might be taught strategies to avoid stressful situations entirely. So how can they de-escalate a stressful situation? So if it's a workplace stress, could they talk to their boss to tackle this problem, or could they look at other social support as a means to tackle and reduce a stressful situation? And obviously in this context, we could look and utilize social support such as Alcoholics Anonymous. It's probably one of the most famous charity organizations that deals with alcohol addiction. Because it's extremely successful. So increasing social support, not just from friends and family, but from other individuals who are also suffering from the same or similar type of addiction. So these are the kind of skills that a patient would learn, and they would be encouraged to use these skills whenever they identify a trigger or whenever they experience a trigger. What's really significant about this type of cognitive behavioral therapy is that a patient is encouraged to write a journal or keep a diary of their experiences. Because the therapist can't be with this patient 24 hours a day, 7 days a week, the patient will go home and they will maybe identify new potential triggers. So it might be a certain situation that they hadn't thought of that makes them feel compelled to carry out their addictive behavior. Or it might be that they report, oh, this strategy worked, and when I felt that compelled to buy alcohol, that strategy worked, but that one didn't. And maybe they could go back to the therapist and say, I don't think that one is successful, but maybe we could do more of these ones that I did report being successful. So keeping a diary is really important because it allows the therapist to really start to tailor the therapy for the individual patient instead of having that kind of one glove fits all approach to treatment. It's really specific for each individual and therefore speeds up the success of the treatment. So here's an activity. I want you to have a go at completing this yourself, so you can pause the video. We're going to do exactly what we've just done, or you're going to do what we've just done together. So you're first of all going to identify the functional analysis, what might be causing Gary to feel compelled to gamble. I'm really going to detail, even though we don't have a lot of information in the source. You can make suggestions like we have done for a potential alcoholic. And then think about the skills training. What kind of skills would we teach Gary? How could Gary be taught to deal with his exposure to triggers in ways that don't result in him actually gambling? You can be as creative as you want, and you can go into as much detail as you want with this activity. We'll read the scenario together. So Gary's addicted to gambling. He's lost over £2,000 in the last month. He often visits the bookmakers, which is just the bookies, the gambling shops where you place a bet, with his friend Mark on his way home from work, and frequently finds himself playing online casino games at home when he is bored. Gary says that he started to gamble when he split up from his girlfriend and finds that gambling often reduces his feelings of loneliness. So that's all I want you to do. I want you to outline the functional analysis, really starting to think about Gary's addictive behavior surrounding gambling. What triggers might be making Gary feel compelled to gamble? And skills training. What techniques could we utilize with Gary? What could we teach Gary to help him deal with these triggers which don't result in him feeling compelled to use online casinos or go to the bookies. So you can have a pause the video and have a go at that answer. If you want to submit your answers, you can do that to me. You can just email them in to me. You don't need to write excessive amounts. That'd be about a 4-mark question in a real exam. We'll just go through the evaluation, then there's one final activity. So again, like I said, these are very similar to the cognitive behavioural therapy for depression. So cognitive behavioural therapy is long-term and potentially a cure for the addiction in comparison to drugs. Drugs often just mask the symptoms of addiction. And if you stop taking the drug, you'd relapse and therefore go straight back to the behaviour that you're addicted to. Cognitive behavioural therapy is effectively treating a patient in the long term. It's effectively curing their addiction, so stopping them carrying out and feeling compelled to carry out their addictive behaviour. And this kind of ties into the second strength of cognitive behavioural therapy. All of the skills that are learnt during the school's training can be applied to other behaviours in the future. So it could be that a patient who was once addicted to alcoholism might show the same characteristics but for another type of behaviour in the future, such as the internet addiction or gambling. If we know that there is a genetic or potential genetic link that explains why some people are more likely to develop addictions than others, if we can ensure that the skills that are learnt to treat one addiction could be applied to others, then we could really be helping patients get back on track and ultimately be in control of their lives. You can't do that with drugs. Once you've taken the drug and you've stopped taking the drug, you can't just decide, I want to take the drug again in the future. It's not as straightforward as that. Weaknesses. Addicts often lack the motivation to complete the training program. It should say training program, to complete the training program, and may only be used when the individual recognises that they have a problem. I'll change this for the actual PowerPoint so that a mistake's not in there. But addicts, because we're talking about cognitive behavioural therapy and we're talking about a therapist actively challenging the way that somebody thinks, and maybe it challenges the triggers and what might cause this behaviour. For a lot of people, they might not like that. So if you're telling a patient, an individual, you're not allowed to see your best friend, or you're not allowed to go to this place, you're not allowed to go to a party, for instance, or a celebration like a wedding, then obviously you get a lot of individuals who will push back and say, no, I'm not motivated, or I don't accept that, I'm going to go anyway. And that can often result in a lot of conflict and tension between the patient and the therapist, where to the point the patient starts to reject and not want to see the therapist for help. And obviously, when we're talking about cognitive behavioural therapy, this is significantly longer to complete before you start to see any potential positive or reduction in the addictive behaviour in comparison to drugs. So a patient who starts to take drugs might start to feel that their addictive behaviour is being treated after maybe 2 or 4 weeks, whereas cognitive behavioural therapy can take months. So a patient might be 3 or 4 months into their treatment program and not necessarily feel the benefits in comparison to if they would have taken drugs. Now, speed is extremely important, because if we have an individual who's addicted to something like heroin, a really dangerous drug, then we don't want to be saying, well, in 6 months' time, if you use this treatment program, you might start to show that your addiction is being reduced. We want to make sure that we're protecting individuals, we're potentially protecting from an overdose. So sometimes drugs and the speed of drugs is a strength that can't be ignored in comparison to psychological therapies. Here's the last activity. It's another exam style question. This is just to get us thinking about data, because research method questions pop up throughout paper 1. They could be absolutely anywhere. So all I want you to do is I just want you to read the scenario, read the source, look at the data, and answer that question down at the bottom. Explain what conclusions the researcher can make when using the data presented in the table. So the data in the table are mean scores. So the scores on average for the patients who complete either cognitive behavioural therapy or no treatment, and the scale is on 1 to 10. So 10 being the severity of the symptoms of addiction. So have a look at that data and write a conclusion. It's 2 marks, so refer to both cognitive behavioural therapy and the no treatment group. Don't just focus on cognitive behavioural therapy. And remember, always evidence. Always actually use the data in your answer to justify and support your conclusions. And again, if you want to submit those to me, you can do. Just send them in via email. We'll start the next lesson. I'll include a model answer for that question. Okay, Year 10, best wishes. See you soon.